Sleep apnea is one of the most prevalent diseases in America today. It's second to diabetes. Sleep apnea also has a lot of issues associated with the cardiovascular system, mood disorders, etc. So there's a lot of comorbidities associated with sleep apnea. To get your sleep apnea under control, there's research and literature that shows that you get your cardiovascular, you get your mood, you get a whole bunch of other components in sync to help your body function properly and with more energy and so forth. So what I'm going to talk about is sleep and how sleep is divided up and what's so important about sleep, and then we're going to talk about a treatment for sleep and treatment for your OSA. I like to take sleep and say basically it's under two umbrellas. The first one is what we call efficiency of sleep. The efficiency of sleep basically is how quickly can you go to sleep. We like to see in our generation somewhere between 6 and 7 hours of sleep, but that's usually not reality in today's society because we have a lot of external sleep pressures, a lot of demands and so forth that we have to take into consideration. But we want to see how quickly we go to sleep from the time we actually turn the lights off, boom, and actually fall asleep and get into our sleep cycles. Sleep cycles are important because there's the REM sleep, which is the bottom part of the cycle that you get into, is the one that you want to spend the most time in. Our target range is somewhere between 25% or greater in the REM sleep cycle. So you have basically stage 1, stage 2, stage 3, down into REM and come back up. And we want to do one of those cycles about every 90 minutes. So the onset from the time you go to sleep to actually when you get into those cycles is somewhere about 90 minutes. Some people it takes a little longer, some people will do it a lot quicker. And then when you get down that cycle, we want to keep you down there and come back up. The other component is how much oxygen you're actually getting while you sleep. It's very important because I use the analogy that if we take a plastic bag, throw it over your head, tie it around your neck and push it in a pool, your sympathetic nervous system is going to kick on. You're going to do everything you can to get above water, rip the bag off, and get oxygen. Well, your body's no different when you sleep. If for some reason you're decreasing the amount of oxygen that you're receiving, you're going to position yourself, you're going to move, you're going to move your jaw, you're going to do something in order to open up your airway. What we see in dentistry is we see a lot of wear facets or inclusions, and the patients come in and say, oh, I'm a grinder at night, I'm stressed. And basically what we do is we run them through a home sleep study test to make sure they don't have some underlying sleep obstructive disorder, and as a result we determine which type of appliance we make, whether we make them a night guard or we make them a sleep appliance. Because if you think about it, we're all nocturnal clenchers, and so if you think about putting your teeth together and you close off your airway, you're trying to position your jaw between every breath to get as much oxygen as possible. Well, each one of those breaths over time is going to wear your teeth out, you're going to get flat. So this is the things that we look at from that perspective. So basically when you talk about cutting off your oxygen, there's two components. One is actually stop breathing, that's called apnea, and the other one is where you decrease in your oxygen desaturation by at least 3% or greater, and that's called hypopnea. You're not necessarily cutting off your airway, but what you're doing is you're decreasing the amount of volume of air that goes into your lungs. And when we look at that, when we look at a sleep study, we want to see both how efficient you are and how much sleep you're getting and how much oxygen you're getting. If by chance you're actually occluding or closing off your airway, that's usually some type of anatomical structure that's created. That's just the way that you were made, and so we look at those when we start doing evaluations. So let's look at apnea-hypopnea index for just a quick second, and then we'll go back to the anatomy component of it. Sleep apnea is determined by using what we call AHI and an RDI index. Both of those guys are very similar in nature with the exception of one element. AHI is apnea-hypopnea index. Apnea is where you actually stop breathing for 10 seconds or greater. Hypopnea is where you decrease the percentage of your O2 by 3% or greater. Those two numbers added together divided by your sleep time is what we call the AHI index. RDI is exactly the same. You have your apnea-hypopnea index, but it also includes respiratory event related arousals such as sleeping, and that's divided by your sleep time as well. Once those numbers are calculated, if they fall between 0 and 5, that's within normal limits. If they're between 5 and 15, that's considered mild. 15 to 30 is moderate. Anything over 30 is severe. Those are indications of whether we use a surgical intervention for severe, we use CPAP treatment, or we use an oral appliance. Anything that in oral appliance arena, anything where you decrease the index numbers by 50% or greater is considered a success. So once you've divided in that and you've been diagnosed with sleep apnea, you've got three choices. One is surgical intervention, one is CPAP, and the other one is oral appliances, which is where I come in. And in those, all three of those have pros and cons associated with them. Let's start real quickly with the surgical, because first of all, you have to be in the severe category. Then you have to be in the high severe category to be considered for surgical intervention. Reason being is because insurance companies, if you want reimbursement from the medical side, they're going to want you to fail CPAP. They're also going to want you to fail oral appliance, and your number's got to be somewhere in the 70s, 80s, or higher range for them to consider you as a candidate for surgical options. And there's a ton of surgical options out there. The CPAP is true and tried. Basically what the CPAP does is, as we begin to relax or lay back, our muscles become atomically relaxed. And so as a result, the mandible that has weight to it, tongue and teeth are attached to it, begins to lay back and close off the airway. And this is where the anatomical component comes into play with regards to what are your obstructions like. What we do here is a little bit unique. We do what we call CBCT, or we use the CBCT to do a volumetric analysis on you. And basically what we do is we put you in a machine that scans your head. It's in a three-dimensional x-ray, so we can kind of spin it around and look at not only your airway volume, we can look at your upper respiratory components, the soft tissue and hard tissue. We look at your palate, your tongue. We look at a whole host of components, adenoids, turbinates, tonsils, the whole bit that we can see, to look at it and say, okay, where exactly is the obstruction? Because here's the deal. If you have a very, very small airway and you have a little bit of encroachment or embarrassment on the airway, you're going to really shut the airway down. If you have to anatomically have a very large airway and you have a little bit of embarrassment, not so much, not going to create such a big deal. So it's important that we know anatomically, you specifically, what exactly are we looking at, where exactly is the obstruction, and etc. So when we look at that, and we look at close-off airways, it's important, especially when we come to appliance and appliance designs. The other component is when we look at the upper respiratory. If by chance you have a high palatal vault, or you were a thumb sucker as a kid, and you push this palate up, the palate itself is going to include the upper airway. So it's important, again, to look at a three-dimensional x-ray to determine where you are and what you are. We do volumetric renderings and volumetric calculations. This is an acrylic volumetric calculation that we pulled out of a patient. Basically what we did is we took their CBCT and sent the data information to a company that actually mills this out of acrylic. This is a volume of 15 cubic centimeters, and this is your basic bottom line minimal volume that we like to see. It sits right about here. We want this as big as possible. Is there an upper number? No. The largest I've seen is 48 millimeters, cubic centimeters. That's the largest I've seen, and I've seen them as small as 6. So that's kind of the range I've been exposed to. But basically, let's talk about the treatment plan, or the treatment modalities for OSA and anatomy. So as we begin to become relaxed, and the mandible and so forth begins to drop back because our muscles become atonic. A CPAP mask, let's take that for example, first of all, is a mask that goes over the head like this, and as this begins to close off, that mask forces pressure to push the mandible and the tongue and everything anteriorly. The problem with that is this, first of all, it's very uncomfortable. People don't like the mask, they don't like the maintenance of it. There's relationship issues associated with it. There's a lot of decay, dry mouth, chronic rhinitis. There's a whole bunch of different issues associated with the CPAP mask. So patients who come to us are those individuals who have been diagnosed with sleep apnea, don't wear the mask, or do wear the mask and want to get out of it. And the only other option for them, if they're not in the high severe category, is oral appliances. So that being said, what we want to look at is what is an oral appliance. There are several different oral appliances on the market. There's probably 100 plus on there, and each one of them has basically the same concept. It basically just wants to hold the mandible anterior forward, bringing the tongue with it. We have a couple of them here. I have a TAP 3 oral appliance. I also have a Somnodent, a Suad, as well as an ENA. All 4 of these, believe it or not, are mine. I've slept with all 4 of them, so I know the ins and outs and the pros of each one of them. I've adjusted each one of them on myself, and I will tell you, even though this one looks the most Hannibal Lecter scariest, this one is the most comfortable of all of them. The number one complaint that I have with it is, first of all, is the acrylic. There's a lot of acrylic and a lot of material that you're putting in your mouth in order to hold your mandible in an anterior position. The second complaint that I personally have with it, we see with patients all the time, is they're made in a either end on end, where in other words your teeth come together end on end, or a protrusive position, in other words like Jay Leno, where your jaw is in more anterior position. If you can imagine holding your jaw in that position somewhere between 6 and 8 hours a day, 365 days a year, what's going to happen is you're going to put a lot of strain and stress pulling the TMJ anteriorly, the temporomandibular joint anteriorly, and you're also going to be starting positioning, changing your bite. There's literature out there that says that over each year of wearing an MAD, a mandibular advancement device, you're going to be moving your mandible 1 millimeter permanently anteriorly. So there's a side effect associated with not only TMD but also occlusal and a jaw position. So I like to kind of steer away from those. I can't prescribe those and I can't manage those, but I like to steer away from those. What I've been really blessed with is an appliance that actually takes a different approach. It basically non-surgically remodels the airway, and we'll show you how that does that. All the oral appliances, what they do is they're made custom for your mouth, and then as you begin to sleep and relax, these muscles become a tonic and hold everything in position. The ones I showed you earlier hold the mandible actually in what we call anterior or forward position. What I like a lot about the DNA appliance system is the fact that it doesn't do that. It's made your natural or habitual bite, and as a result it basically keeps the mandible in position. Now what's really cool about it is you can move the mandible if need be, but what we have seen is holding the mandible in a specific position and not letting it drop back and training the tongue to stay anteriorly. We're seeing these people or these patients who come in who've been diagnosed with mild, moderate, and severe as well. We're seeing their numbers decrease. So it's a phenomenal device. First of all, if you look at it, you can kind of tell that it doesn't have near the acrylic that the other one does. And the really cool thing about it is the fact that the wires themselves are patented wires. They store energy in them, and the design, the 3D axial springs, are patented as well. So basically it's like a retainer, and when you put it in your mouth and you swallow and you talk it in, your teeth clang against it, you're storing energy in those wires. Those wires vibrate at a high frequency during your circadian rhythms, turn on cellular growth. So what is it doing? It's widening your arch, it's lowering your palate, and it's reforming non-surgically the cranial base, or the cranial features, the maxilla and the mandible as well. So that's what's really cool about that appliance. To this day, I have had not one patient with any side effects associated with it. They've all come back very comfortable and really enjoy the appliance system. So let's talk about the one for sleep a little bit more closely. This is called the MRNA, Mandibular Repositioning Nighttime Appliance. It's very cool in the fact that I can actually control the growth, development, and the structure in three-dimensional space. I can do everything from moving the mandible forward, backward, keeping it in position. I can open up the vertical where your teeth come together, the top and bottom. I can widen the arch from a transverse and also an AP direction as well. There's a lot of moving parts and a lot of adjustment components associated with it. But the coolest thing about the appliance system itself is the OSA extension in the back. This little extension with a little ball on the back is really cool because it does two things for us. In my example here, in my airhead, we have a mock-up of the OSA extension on the back of the plate there. And what's really cool about it, as the individual becomes relaxed and lays back, the mandible is held in position. But the tongue has the ability to move. So as the tongue comes back, it engages into the bottom of the OSA extension, and as a result, it begins to train the tongue and say, hey, you can't come back here, you need to stay forward. So subconsciously, as your tongue comes back and relaxed and it comes engaged with the OSA, it's automatically moved forward. The other cool thing is, when we talk about snoring, this is your hard palate and your soft palate. You have laminar airflow that comes across that area, and as a result, this soft palate becomes relaxed during sleep, and it vibrates as air goes across it. As this becomes relaxed and engaged into the top of the OSA component, it strengthens itself up, it tones itself up. It says, stay taut. And so it's really a cool adjunct to keeping both the training the tongue to stay anteriorly and also keeping the soft palate in a contracted state. Now here's the trick. If you're going to train your tongue to stay anteriorly, what if there's no room for it? So that's what's really cool about the MRNA, is the fact that as you're training your tongue to stay forward, you're also keeping your soft palate on, decreasing your snoring, hopefully getting you into cycles where you stay down at REM. We're actually reshaping the maxilla and the mandible. So if we're broadening the upper arch, broadening the lower arch, keeping the occlusion and the bite in its natural position, and training the tongue to stay forward, we've really increased or opened up your airway. And so that's what's really significant and phenomenal about this appliance system. So just kind of do a little quick recap. Is the fact is, first of all, we will look at how efficient you are. Are you going to sleep quickly? How long you're staying asleep? How many times you get into that cycle? Are you having obstruction? If you're having obstruction, as you begin to close off your airway, and let's say you're in stage 1 or 2, you're going to wake up, move, you're going to position your mandible, you're going to go back up to stage 2, stage 1, and you're not going to get down to that rim. If we can get you down that REM to stay in REM, two things happen. You decrease your snoring, your mind begins to break up, you start to get rid of the old stuff, get in the new stuff, you feel refreshed, energized, a restful sleep when you awake in the morning. The other thing is again, keep in mind that when we do volumetric airway studies, we want to see exactly what your volume is, where you're at, where your obstruction is, and address that with the appliance and the appliance design. So that's really what's really phenomenal about this appliance. A couple things that are consistent with the appliance itself is that when patients come in, they say these same things over and over and over again. First of all, I've never slept better, felt better with the appliance. Second of all, if I dreamed, my dreams were more vivid. Or if I dreamed and didn't remember my dreams, I now remember my dreams. So it's really a phenomenal little adjunct, a little toy with regards to getting individuals to get into REM sleep and so forth. The other thing is if for some reason we have to remove the appliance and have a modification done, have a repair done or something, patients go a little crazy. They call every day, is it back, is it back, is it back? They can't live without it. It becomes a pacifier. So it's really a phenomenal device. I actually wear one myself. I've experimented and played with wearing it and not wearing it in certain events, and I will tell you that I have got to the point now I'm through experimenting, because the nights that I don't wear them, the days that follow are really challenging for me to get through. And so as a result, no matter what, I will definitely wear the appliance and the appliance system itself. With regards to how we actually do that here on the appliance, first of all, we have to have a sleep study. If you have a current sleep study, we'll use that for the baseline. I don't need a titration study. A titration study is not going to help me, other than to tell me if your pressure is elevated. I know that you're a little bit either mild, moderate, severe based upon your pressure setting. So I'd like to have a baseline with nothing in it, no titration, no CPAP or anything. Once I get that core information, that gives me a baseline to start with. If you don't have one, what we do is what we call a home sleep study test. They're watches that we program with your data and information in them, and those watches you sleep in your bed. You drop them off, and the next day we download them, and then we actually interpret those and determine if you have mild, moderate, severe sleep apnea, and so forth. If you have a current sleep study and you elect to move forward with the appliance, we still run a baseline with our HST, because the data comes out exactly the same consistently, because what we do is we monitor you as you go. So then what we do is we do the CBCT, where we do the three-dimensional x-ray, we do the volumetric calculations, so we see exactly where you are, and then what we do is we do a tremendous amount of photographs, intraoral, extraoral, we do impressions to make the appliance. All the appliances are handmade. They're made in Salt Lake City, Utah. It takes somewhere between 3 to 4 weeks to get them back. And then when we deliver those guys, we review your sleep study, we review your volumetric analysis. We also do what we call myofunctional therapy screening to look at your tongue and training your tongue. I have 2 hygienists. Both of them are trained for myofunctional therapy, so they help your tongue move forward. Not only is the appliance going to continue to train your tongue, but there's a series of exercises that you do, and you get each time that you come in for the adjustment. So we deliver the actual appliance, the appliance system to you. We make sure it fits in, we make sure you can take it in and out. We give you instructions, we give you a spa bath to clean it and keep it clean. And then what we do is we let you sleep in it for the first night. We call you the next day, hey, how did your sleep go? Is everything good? Do you have any issues or problems? Is there anything pinching? And if so, we see you immediately to make those adjustments. If not, we give you about a full 5 days, a week or so, a week, 10 days max, to wear the appliance to get used to it. Then we run another HST on you, so we look at your baseline, and we'll look at your 5-day or 10-day baseline, and then we adjust or go from there. Then we see you every 4 weeks for the adjustments, and then every 90 days we retake your photographs and we now run an HST to see the progression of where you are and how you're doing. My goal is to get you from where you are to where you need to be, and whatever it takes, we're here to help, because our goal is to make sure that we get your OSA under control and we make it a pleasant experience for you and make you get more energized and change your life with regards to your health.